going to introduce Marzyeh and her many, many accomplishments, and a resume that just reads like somebody who's been in the academy for many, many more years than Marzyeh has actually been, but accomplished so much.
Just the highlights.
I'm going to give highlights, but it's going to take a little while.
Oh no!
But before I do that, I want to introduce the members of our data science committee, and they've been incredibly helpful in planning this and thinking through both now and into the future what data science might look like at Boston College as we think about data science being an enterprise that we do in many of the departments and many of the colleges here at Boston College. So the members of the data science committee: Sergio Alvarez from computer science, Elizabeth Howard from the Cornell School of Nursing, Mo Jones Jang in the Department of Communications, Kimberly Cowell in the University Librarian, Mandy Lee in the Lynch School, thank you. Bob Meyerhoff, Chairperson of Mathematics, Emily Singley, University Librarian, Brian Smith, Associate Dean for Research in Lynch, Howard Straubing, Chair and Professor of Computer Science, Ethan Sullivan, Associate Dean for Undergraduate Programs in Carroll School of Management, Sasha Tomic in the Woods College of Advancing Studies, Gautam Yadama, Dean and Professor of the School of Social Work. So I think what you're seeing here is that we have a very collaborative approach to data science at the university. And I think Marzyeh is a great person to kick us off because her approach to computing and data science is indeed interdisciplinary by nature. So what we're going to do is Marzyeh is going to speak for half an hour or so, and then we have two esteemed panelists who will comment on Marzyeh's work, and then we will have questions and answers from you in the audience. Our two esteemed panelists are Summer Hawkins. I'll introduce her in more detail shortly, and Sergio Alvarez from computer science. So Dr. Marzyeh Ghassemi is the Herman L. F. von Helmholtz Career Development Professor at MIT. She has appointments in the Department of Electrical Engineering and Computer Science, the Institute for Medical Engineering and Science, and the Vector Institute. She holds a Canadian Cypher AI chair and a Canada Research Chair. She was recently named one of MIT Tech Review's 35 innovators under 35. So Marzyeh holds a PhD in computer science from MIT, a master's degree in biomedical engineering from Oxford University, and she was a Marshall Scholar, and a BS degree in computer science and electrical engineering as a Goldwater Scholar at New Mexico State University. There are many, many other items I could read about Marzyeh. I do want to mention that her work has appeared in many top journals, including Nature Medicine, Nature Transitional Psychiatry, and Critical Care. And her work has been featured in popular press such as MIT News and Huffington Post. She is on the Senior Advisory Council of Women in Machine Learning. And she was awarded MIT's Seth Teller Award for Excellence in Inclusion and Diversity. So Dr. Ghassemi's talk will be using healthy machine learning to enable equitable health outcomes. I turn the table over to you.
Thank you. I'm going to steal the mic for the Zoom people, and hopefully it's still working. I sometimes have dinner with the junior faculty at MIT, and last night we were having dinner, and they were saying, that awkward situation where there's a room of people and they're reading a list of names, and you have to acknowledge that your name went, and I was like, that never happens. And then they said, well, if it did happen, what would your thing be to acknowledge that your name had been read? And one of them said, well, I dab. Another one said, like, I do. And now I feel really stupid that I didn't make an official, I do a queenly wave when my name is called. So thank you for inviting me. I'm very happy to be here. Hopefully it won't take too long to get through my contents. So I'm going to talk to you about using what I call healthy machine learning to enable equitable health outcomes. The first thing I want to go through is the idea that the data that we're using is actually embodied data. And this is very true in health, but it's also true in other areas, right? If we're talking about transportation, if we're talking about anything else that is data that we generate, as long as there are humans in the process, it's embodied data. And in the case of health, it's actually from human bodies, right? And so it's very important that we understand that this is real data from real people. And if we want AI to improve health and possibly address some of the issues that we see in healthcare, then we need large amounts of diverse data for research use. And I want to emphasize this because if you're not in the space, you may think that it's very easy for academics to get access to health data. But the reality is that a lot of intellectual property constraints actually dictate that it's very difficult for researchers to get access to large amounts of diverse health data. This is a quick quiz, so you know, I won't grade it, I promise. This is a real table of real papers that was in a paper that Eric Topol wrote a few years ago now. Every single one of those lines is a model that a machine learning person like me or one of my students trained, and then they evaluated how well it did on a specific task, right? So you can see predicting suicide, sepsis, C. diff infections in the hospital, which is a hospital-acquired infection, it's very severe. And in each of these cases, the clinical AI performs at or above humans. Okay, so they evaluated this and it says it's performing better than a human could, as well as or better. So the question is, you know, it's post-pandemic times, but according to my ICU friends, ICUs are still kind of busy, it's kind of full. If you were going to the emergency room and one of these fancy hospitals like MGH said, hey, we have a brand new machine learning triage system. We have a published paper in Nature Medicine that says it does as well or better than doctors at triaging you, determining which unit you should go to. And it'll take 10 minutes, but it's going to be a couple hours for you to see, you know, like a triage nurse. We're really swamped. Would you take the AI model? I mean, show of hands, who would take the AI model? Some people would. There's a reasonable number of people who would. For somebody who did not raise their hand, why didn't you raise your hand? What questions do you have? Go ahead.
I mean, people have to decide what goes into the AI models, and I don't know if I trust the people who aren't there in front of me.
Aha! So this is, I think, the big thing. Every single one of those numbers is an aggregated performance. You don't know what went into the design of the model. You know it does better on average for most people that they evaluated on some set of clinicians. It's unclear whether they compared, for example, to the best clinicians available to average practice. It's also unclear what the subsets of performance would be. So a lot of these models, as you'll see, do not perform equally well on different kinds of people. And that can be based on race and ethnicity, that can be based on pre-existing conditions, it can be based on socioeconomic status. So the problem here is that AI learns from human practice. And I show this slide because once a very long time ago, when I was giving my first set of job talks, I showed this slide and said, you know, AI learns from human practice. And this was not at this school, it was at another school. And it was a panel of people who really believe in technology. And one of the people said, yes, we want our machines to be like Dr. House. And I said, he was a drug addict. Were we watching the same TV show? We do not want our machines to be like that man. So here's an example of something that an AI model can do very well. You've probably read about this. If you've heard anything about medical AI, you've heard this, that we can take chest x-rays and we can predict diseases. This is actually an important problem. There's a global shortage of radiologists, and it's an important diagnostic tool, okay? Real problem, tedious work, something AI can do well, right? So we took the 3 large public chest x-ray data sets from Stanford, MIT, and the NIH. That's over 700,000 images, okay? So we have a lot of data. We're not underperforming here. And we trained a dense net model, which is just a kind of convolutional neural network that works really well in images. And we trained it to predict outcomes of interest, but then we trained a second model to predict no finding. Why did we train it for this? Because it's a real triage situation. When somebody comes into the hospital, you want to know if they're healthy so that you don't have to give them emergency care, right? Like, they can stay in the general ward for a little while. We don't need to do anything. And so you could imagine this would be well used, especially in emergency situations. And here's the problem. We're going to compare the false positive rates of this model in different subsets of people. Why are we going to compare the false positive rates? Because a falsely positive, you are healthy diagnosis means you are underdiagnosing one subpopulation more than another. So what this would mean is, for example, if we had a higher false positive rate for female patients, it would lead to disproportionately more underdiagnosis and non-treatment for people who actually need treatment. Okay? So what we found training this state-of-the-art performance, I want to emphasize, model on 700,000 plus chest X-ray images is that these models have the largest underdiagnosis rate on female patients, young patients, Black patients, and patients on Medicaid insurance. And it gets much worse when we look at intersectional identities. So for example, Black or Hispanic female patients are significantly more likely to be underdiagnosed by the model than white female patients. So this is a terrible problem. And you might say, well, it's very good, as one reviewer did, who I hate this person. I know who they are too, because they said you should cite these 7 papers with the same first author. It was very obvious who it was. They said, well, why don't you just audit the model? I'm like, we know, that's why we wrote the paper, to tell you should audit your models. So in many cases, you can audit a model. It's possible, right? You can look at specific intersectional subgroups. Maybe we can look at ethnicity, insurance type, and gender and say, we want to make sure that our model doesn't perform more than some delta from some specified performance. Okay, so that is a possibility in some cases. However, let's take another kind of model. Have you guys heard of GPT-2, GPT-3, these BERT models? These are transformer models. If you read the New York Times or the New Yorker, they have these guest articles that are sometimes written by AI, okay? And so those AI are what we call transformer models. They're contextual language models that have learned on billions of examples of human text generation. And now when you give them a prompt, they can either fill in a blank or generate new text that is, to my eye and the eye of many experts, indistinguishable from human text, okay? So it's very good. It's very high quality generation. So we took a very specific contextual language model. We took not BERT, which is trained on the trash of the internet. We took SciBERT, scientific BERT, which is trained on PubMed abstracts. So this is scientific articles, right? And it's being used right now. So I've used it before to do autocompletion for neural network generated radiology notes, right? Okay, so machine learning researchers use it. It's trained on scientific articles and it generates valid text, okay? And we gave it this prompt. This is a real prompt from a real patient's note in the Boston area, and it's blank patient became belligerent and violent, sent to fill in the blank. If I say Caucasian or white, the model says send that patient to the hospital. If I say African, African American, or Black, the model says send that patient to prison. It's a public model. You can download it right now. You can use it. I have used it to fill in blanks. This is very hard to find. This is not a simple audit, right? And so these are not things that you can simply look at a surface value and then say, well, we thought about it, we did this one audit, and now it's been addressed. Because bias is a very deep part of the clinical landscape, not because doctors are evil, because doctors are humans, and humans have biases. So if there's a bias in society, you will probably see it come up in clinical care in ways you do not expect. And I'm here to tell you because, I have a new genre of papers, which are an annoying reviewer said something and now I will prove them wrong paper. So this is one of those papers. It's coming out in iClear this year. And so an annoying reviewer said, you're making this big deal about how when you have biased data, you learn a biased representation. Well, what if you just learn that biased representation, because that's what we have right now. And then later, through efforts, we get balanced data. Fixes the problem. It doesn't fix the problem, according to our paper. So what happens is, if you learn a biased representation here, for example, we found that even when you rebalance so that it's perfect later on downstream, the representation itself is biased. And so if we were thinking about faces, right? If we learn on a data set that has very, very few Black faces, the representation that we learn is inherently worse at distinguishing Black faces because it's seen fewer examples and it paid a lower penalty for getting those few examples wrong. And so now, even when we rebalance and have a 50-50 data set of half Black and half white faces later on, it doesn't fix the problem. We still see evidence of this downstream bias. So this leads me to the areas that I focus on in my lab. So I focus on 3 things: how to make models healthy by looking at sort of methods that tend to encourage robustness, fairness, and privacy. What healthcare is healthy? Can we use established tools that exist to audit healthcare systems and perhaps point to room for improvement? And finally, what behaviors are healthy? Because even if you have the best model in the world, you have to make sure that the human using it is actually using it correctly. And hopefully this will, at the end of a lot of research, help to create actionable insights in human health. So let's pretend we have a patient named Sumana, and she's having trouble breathing, so she goes to the ICU. So we wrote a paper about clinical intervention prediction using the Mimic3 data set. So if you don't know, this is a publicly available data set that once you pass the research ethics certification, anybody can use. It's not based on who you know or some amount of money. It's openly available. So I'm a big proponent of this. It's a big reason I moved back to MIT, because I believe in open science. And so let's learn with real patient data from the BIDMC data set. So what happens in all these papers, remember I showed you that big table from Eric Topol's review, this is what we all do. It's a thing, we all do it, we all know that we all do it. We take in patient data, and then we set some fixed point for prediction. So for a ventilator, it's like 12 hours, right? So every 12 hours, predict whether all the patients in the ICU might need a ventilator in the next 6 hours, because that's actually how hospital planning happens, right? I need to know whether I can send, the senior residents home. I need to know if I need to have more equipment available, things like this. And then it's important that you do this real-time prediction, because this is all data that's actually happened. And so the way that we evaluate is not we go experiment on patients in the ICU. We take a patient's data of a real person who actually went through the hospital, and we play it forward in fake real time. And then we see whether the model got it right. So that's how we sort of evaluate what we're doing. It's also very important that you do it by some clinically relevant gap time before the event happens. Because if you predict a patient is going to die in the ICU 12 hours before they die, that's silly. In the ICU, in a modern ICU, if you don't know, you could keep a rock alive. It's very, very good, but it's not a meaningful sort of sense of life. And so, you have to really say, we need to know what signals are proxies for our outcome as well. So here's what we did. We took over 30,000 ICU patients' data. We took static variables that don't change during the admission, time varying things that change very frequently every hour during the admission, so vitals and labs, and then all the clinical notes for every patient's stay. We turned clinical notes into a vector representation using topic models, so everything is now a numerical representation. That means every patient is now a matrix, a big matrix of numbers, which means all the patients are a big tensor of numbers. And the reason it's important to do a lot of this kind of engineering work to think about how to turn the data that we have into a big tensor is once you have a big tensor, we have many ways of modeling a specific outcome of interest. And I'm just going to focus on what we found with the recurrent and convolutional neural network models, which is even with high capacity models, it's very important that you think about your representation. And so here we did a physiological word representation where we allowed missingness to be a value that was represented in the data instead of just imputing it with something else. And that helped the neural models a lot, especially when we have lower proportion of positive examples. Also for the more severe interventions, so ventilation versus non-invasive ventilation or administration of vasopressors, which up your blood pressure, or fluids, which are also to help with systemic blood loss. And also, there are really interesting things that you can see here. So we did feature level occlusions to try to understand which data is helping with which tasks. And it turns out that a lot of the physiological data is really helpful for predicting severe interventions like ventilation. But if you're thinking about things that are less severe, like a fluid bolus, then the words are more meaningful. And so you really do need all of the data to learn on. And then you can also ask your models to hallucinate or give you the most likely trajectories that would have led to ventilation or a vasopressor, and they match with things that we know physiologically tend to lead to these interventions. All right, that was a really cool demonstration. I did that 5 years ago. And then this year we did something different. And we did something different because in practice, it's very hard to hook my neural network up to your electronic healthcare record. Not for technical reasons, for honestly, infrastructure reasons. And so because it's so hard, but I would still like to evaluate the models that I'm doing, we need a simpler way to deploy these things, okay? And so we looked at these decision support checklists. These are very common in medicine because they're easy to use, easy to deploy, and very easy to verify. What I mean by that is it doesn't have to have a direct pipe into your EHR. I can just, if one of the components has a blood pressure over 50, I can just look over, yep, over 50, right? So they're easy to sort of do these deployments and verification. There's two problems with them. Number one, you have to create the checklist. So the way that these are happening now is you get a big panel of domain experts and you put them all in a room together, sometimes for months, and they just have to assemble all of the expertise and look at all the papers and come together and make this consensus checklist of this is what we agree on. That takes a lot of time and it's very difficult. And then, even after you do that, even after you make these checklists, years later, so this is a great paper that came out a few years ago from Harvard, we'll find that these clinical algorithms, these are risk scores that were made by and verified by panels of experts, actually do very poorly for some subgroups of people. And so this paper specifically goes through all of the different risk scores that we have in many different settings and finds that really there are these big gaps in over and under correction for African Americans in different clinical settings. So what we'd like to do is learn optimal predictive checklists. And the way that we're going to do that is with mixed integer programming. So we take all of the data from the different ICUs, and then we're trying to learn what is the optimal way of predicting an outcome. And the nice thing about mixed integer programming is that you can have problem-specific constraints. So I'm going to give you a real example. There's a kind of treatment called continuous renal replacement therapy. It is a end-of-life care, very aggressive treatment. So you don't want to have it if it's not going to work. And it's also very painful and expensive. Okay, so this is a treatment where really if you're severely ill, they can use it, but you don't want to use it if the patient is going to die anyway. Okay, and so a useful thing to predict, according to the two ICU doctors that I collaborated with for this, is whether somebody will die after CRRT. And if there's a high likelihood, then that should trigger an interdisciplinary consult where you talk to the patient, you talk to the family of the patient, you talk to the specialist and say, is this something that we really want to do? Okay, it's very important here for obvious reasons to ensure fairness, because you don't want to always say like, don't give this intervention to any of the Black women, they'll just die afterwards, right? So it's very important that we ensure intersectional fairness here. So here is the model that we trained with no fairness constraints, and you can see it does not use gender, does not use ethnicity. I gave this to the two ICU clinicians that I work with, and they said, that looks great. That's a great checklist. The performance is high enough. We would totally deploy this. Predict mortality if 3 or more items are checked on this list. But this model actually has a max false positive rate gap of over 50% between white men and Black women. And it's not using gender or ethnicity. And it's because there are really, really deep proxies for these things in health data. So look at that. Time in the ICU, what do you think that's related to? Your insurance. And what do you think insurance is related to? Socioeconomic status. And what do you think that's related to? In some places, it's related to race. And so if you add in race, or if you add in intersectional identity constraints, you can reduce that gap, but it comes at the cost of reducing your overall performance because there's no free lunch here. You can't make it better for every intersectional subgroup and then also better for everyone. There are trade-offs that come into play because it's a constrained problem. You have this much data, you have this much information, right? The final thing that I want to talk about is, we've done all these interesting models and we can do all these amazing audits, but in the end, there's going to be a clinician that sees the model recommendation and that clinician is going to actually make the decision, right? So have any of you ever volunteered on a mental health hotline or crisis line? So I did after college. And what you do is you have limited liability because they train you for a week and you're going to get help no matter what, right? So you're either going to send the police or an ambulance to help somebody. And so you have two options. You can send either of these, right? you get a transcript. So what we did is we surveyed a bunch of clinicians and non-clinicians, and we gave them this transcript, which we took from several mental health line transcripts and then modified the details. And we asked people to make a decision. We wanted to see whether we would disproportionately more see people call the police for help instead of medical help for African Americans and Muslims. And it turns out, with no advice, people, regardless of their stated attitudes towards policing, regardless of their stated political beliefs, regardless of gender and job, they are fair on this. They do not call the police disproportionately more when you vary African American or Muslim from Caucasian or Christian. And then we trained an evil GPT-2 model. It's very easy to do. You just give it a couple thousand bias sentences, and suddenly it always thinks that you should call the police on Black and Muslim patients. So, and then we allowed this evil model to give advice to some of the participants. This all went through IRB, I promise. It's an ethics review. Nobody was too traumatized in the making of this paper. So we have a model that's going to give advice that's evil, and we know it's evil because we made it evil. And then we have a model that's going to give advice that is fair. We know it's fair because we made it fair. And we're going to give the advice, evil and fair, to people in two ways. We're going to give some prescriptively, where we say, in this situation, our AI model thinks that you should, and then call for police or call for medical help. And we're going to give it descriptively, right? So our AI system has flagged this call for the risk of violence. It's just as biased, right? But there's this very small difference in how we're conveying the information, that this very biased information, and they make the same decision. It turns out fair people who get really biased advice descriptively stay fair. And fair people who get really biased advice prescriptively always listen to the model. Which is a little bit concerning because, you know, we really didn't expect actually to see clinicians be so biased by the prescriptive AI advice, but they are. And so this is a really important thing, I think, for us to know, because this has nothing to do with training the model. It has nothing to do with the model or the data. Models will be wrong sometimes. Nothing is perfect. We need to be able to give advice in a way so that when it is wrong, people don't just blindly follow it. And this is not something that I think traditionally, or even now, myself or other people in my field really think about. We think we train the best model, it'll be wrong occasionally, here, go and use it. So this was a fun but disturbing study with an interesting result. So the thing I want to leave you with is that there are no simple fixes for ethical AI in health. In many spaces, this is also true, but in health particularly, you have to think through an entire pipeline of reasons that you might want to have differences from maybe the current status quo for collecting data, defining problems, and doing deployments. Currently, health is really lagging in other, as compared to other AI fields in terms of our openness and reproducibility. And that's because data sets are kept by, for example, large hospitals, and they don't want to give it to you unless you pay them lots of money or give them your firstborn of all papers for the rest of your life. You laugh, but and really, you know, in this talk, I've covered things that I think are the tip of the iceberg. I think there are many other issues that are very important, but these are the kinds of things that I think maybe are addressable right now and will lead to improved penetration of these other issues. And a final plug is for some of these open tools that exist. So these are data sheets for data sets, model cards for model reporting, which I'm hoping will become a standard in some of the machine learning for health areas. This is work done by a fantastic lab of students and collaborators. And thank you for inviting me.
Marzyeh, thank you very, very much. That was fascinating. You know, something that just comes to my mind, given that especially the end of your talk, is about the model, how people were willing to accept what a model told them as opposed to what a person told them. Right? They were able to, when the model spoke, they put aside their own thoughts about fairness and went with the model. And this is really very consistent with the talk we actually, the Schiller Institute also co-sponsored last night with Ruha Benjamin, who's a sociologist who looks at science and technology and its connection to critical race theory. And one of her major points is that people tend to believe what models tell them.
Yes.
That we believe that there is objectivity in the results of predictive models, even though those models, as you were saying, even though those models are created from human input with human bias and racism built into them. And so what I just heard here is a fantastic example, based on a lot of data and a lot of your research that makes her point really, really well, brings it home. So really appreciate that connection between the two talks that Schiller has just been sponsoring in the last couple of days, and how powerful your example is on that.
Thank you.
What I want to do now is introduce our two panelists. So our first panelist is Summer Hawkins. Dr. Summer Hawkins is an associate professor in the Boston College School of Social Work. She's a social epidemiologist, and her research examines the impact of policies on health disparities in parents and children. Dr. Hawkins applies econometric techniques to evaluate natural experiments created through policy changes within and between US states. She's worked on such topics as tobacco control policy, breastfeeding policies, and the Patient Protection and Affordable Care Act. She's been published in many prominent peer-reviewed public health journals, and she's written on such topics as parental smoking, infant feeding practices, and preventive health services. I'm also happy to say that Dr. Hawkins was awarded last year a grant from the Schiller Institute, a grant for exploratory scholarship, collaborative scholarship entitled Evaluating the Health Impacts of Disasters on Youth. And her collaborators there are Dr. Betty Lay from the Lynch School and Kit Bound from the Economics Department. So perhaps Dr. Hawkins would take a seat in front. And I also want to introduce our second panelist, Sergio Alvarez. Dr. Sergio Alvarez is an associate professor in the Department of Computer Science at Boston College. He is the head of the Machine Learning Lab, and his research specializes in data mining and machine learning, and particularly as applied to clinical health. So Sergio, perhaps you take a place at the panel as well. I want to remind folks that we'll have about 10 or 15 minutes of talk from our two panelists. Then we'll open it up to questions. And very importantly, we are serving lunch after this. So we'd love you to stay and have lunch with us and talk with Marzyeh and Summer and Sergio as well, and also talk with each other. So that said, Summer, do you want to lead us off?
I'm good. I don't usually use a mic like this. So, but anyway, thank you, Laura, so much. It really is honored to be invited. Just such a pleasure to have you, Dr. Ghassemi, and to hear more about your work and how you're really pushing the field forward with AI in ethical and just ways. So, as you've heard, though, I'm a social epidemiologist and I don't do AI. so you can imagine what I'm doing up here, but I do analyze big data. I've used birth records, mortality files, health insurance claims data with geographic identifiers, really to evaluate natural experiments, and created through policy changes within and across states. And as Laura said, I collaborate with Professor Kit Bound, the chair here in economics. And for example, we've recently been analyzing the impact of county and state tobacco control policies on disparities in prenatal smoking and birth outcomes. These are county level data on all births in the US from 2005 to 2018. So we're looking at 40 million babies. So I often consider how we can use existing data to gain new insights. I have 3 points that I want to highlight in Dr. Ghassemi's talk, which also overlap in my own work. They are the areas of intersectionality. They're what I'm going to call a data problem, and then also a people problem. So first, intersectionality. So Dr. Ghassemi presented on a model based on chest X-ray diagnosis, which resulted in underdiagnosed rates in females 0 to 20-year-olds and Black patients. However, intersectional identities had higher rates of underdiagnosis than those in single categories. For example, Black and Hispanic female patients were underdiagnosed more than white female patients. So I think a lot about how policies on populations do not occur in isolation, but as researchers, we often investigate them as if they do. So last year, Kit and I published a commentary in the journal Pediatrics on evaluating intersectionality. We often put variables in our models separately, right? Race, ethnicity, education, age, because it's easy, not because it represents the real world. For example, we found that when evaluating tobacco control policies related to prenatal smoking, there was a significant interaction between women's race, ethnicity, education, and cigarettes, such that low-educated white and Black women have the highest rates of smoking or the most responsive to taxes, which also improves birth outcomes. But looking at either race, ethnicity, or education separately would not have identified women at the highest risk and really would have missed how cigarette taxes are actually reducing this disparity. So I think we all need to consider more about how we can ensure our data represents or reflects the populations we work with, rather than do what made easy. Second is what I'm calling a data problem. And we often use data that are readily available, but it's critical we step back and consider who is in the data set, right? Is there bias in how the data are collected and who ends up there? And as you pointed out, right, that focusing on convenient samples can exacerbate existing disparities in marginalized populations. And if we use data that are convenient, we may not be capturing information in the most vulnerable and possibly the highest risk. So you can imagine that I then would say, look, we need to then use population level data sets, right? And so I tell my students when data are collected on everyone, right, we're not worried about bias and who gets into the data set, right? It's everyone. But I think we need to reflect that it's probably not that simple. We sometimes forget that data may not be collected the same for everyone. And so while I'm not a fan of anecdotes, right, NM1s is not something that I talk about ever, but I'm going to tell you a little story to illustrate this point. So after I had my first daughter, I was really excited to complete the documentation associated that would go in the birth certificate. And one of those questions is how much you smoked during pregnancy. So after I had my second daughter, in the delivery room, a nurse asked me, quote, "You didn't smoke during your pregnancy, did you?" So while I had not, would I have felt okay saying that I had smoked when she had framed the question that way? So again, it was asked, "You didn't smoke, did you?" So it makes me reflect, are all women being asked this way or only some women? And while I like to think that data sets of 35 or 40 million can handle a few errors, right? It makes me consider what other data elements may be biased. And Kit and I have also analyzed all payer claims databases in Massachusetts, Maine, and New Hampshire, which contain health insurance claims for everyone in these three states who are publicly and privately insured. So 2 brief points. First is we're limited to the data elements that are there, right, that are collected. We only have information, for example, on patient sex, age, and zip code, but other variables such as race, ethnicity are not consistently collected. We know whether someone's privately insured or on Medicaid, but what about the uninsured who don't make it into our database? And research shows that populations who have greater barriers to accessing healthcare show up less in our data sets and appear to use or quote unquote need, right, less services. So I was listening to the Freakonomics MD podcast the other day, sorry, a pleasure, I guess, in my spare time. And Dr. Gurpreet Dhaliwal, professor of UC San Francisco, said a phrase that stuck with me. So we often talk about data quality impacting our results and how it doesn't matter how fancy our methods are, but we often say, garbage in, garbage out, right? This idea that if we put garbage into our model, we're going to get poor quality out. But he said a phrase that is very relevant today, which was actually bias in and bias out. It's not just the data, but the researchers themselves. And so I'm going to my last point very briefly is what I call a people problem. So researchers bring in their own biases, as we've seen that affect their work, whether that's with AI, clinical medicine, or social epidemiology. And so I don't have the time to go into this. Dr. Ghassemi points out that we need diverse data and diverse teams. We need teams of researchers that have both very lived experiences and backgrounds, but also different training. So coming at a problem from different perspectives often provides new insights in how to solve it. And I'm a true believer in interdisciplinary teams and often say that the outputs are better than any one member could have produced alone. So at BC, I think we need to consider how we're training the next generation of researchers clinicians, and scientists. How do we get students to step back and reflect about the biases that may creep into our data, our analyses, and even ourselves during this process? So I completely agree with Dr. Ghassemi that new perspectives and tools are needed to address these biases. And that regardless of our discipline, in order to improve population health, we need to generate evidence that truly represents the communities we serve.
Thank you so much, Professor Hawkins. Dr. Alvarez?
Thank you. So first thing I want to say is that I just witnessed a tour de force. Machine learning in health. Really, Marzyeh is just an impressive body of work that she's done. And I think you're seeing work of the highest quality. So I think we're all lucky to be here and learn a lot from everything that you're doing.
I have to tell, I told Laura, my advisor told me when I joined MIT, just be careful, it's a praise-free zone. And he's right, nobody says anything else. And so they do it out of love. But I've gotten too many compliments today. I'm like, oh, so many compliments.
So I wanted to emphasize some of the points that you made. Maybe add a couple of things in there that all of it is food for thought. It's very important work. As I said, the first thing is Marzyeh, you started and you ended by saying that broader studies are needed with more representation of certain groups that typically don't make it into the studies, and that is so important. In my own work, I also wrestle with that problem sometimes, especially if you're doing secondary data analysis. Very often, the information that you need to do something like a subgroup analysis across race or gender is simply not there. And so in particular, when you're doing intersectional sorts of analyses, right, the sample sizes get so small that it's very difficult to do any kind of statistically significant inferencing from that. So it's extremely important to have these richer data sets. And NIH, for example, has this program, right, All of Us program, research program. They're aiming to get data from over 1 million people across all sorts of ethnic and socioeconomic groups. So I think that's certainly a step in the right direction. So people are clamoring for this sort of thing. There's a need for more of it. Another thing is, obviously, it's extremely important to address bias, as you pointed out so forcefully. And so that's certainly something we need to do.
Since you're just the person, share your microphone as well.
Hello? Oh, it is. I guess I'll speak a little louder, perhaps.
That's great.
Okay. And so addressing bias is certainly important, but addressing bias is not enough. As we've seen since many, many years ago, people have been worried about machine learning. Just think back to a few years ago when there was this whole craze about self-driving cars. Now, that hasn't gone away completely, but I think people realize that it's a little bit too early to deploy these things, right? There are hidden dangers that we need to be aware of. And it's really not just release critical sorts of processes to machines on their own. And in fact, I was looking around, Norbert Wiener, over 60 years ago, wrote a paper in Science where he addressed social, moral, and technical consequences of automation. And he said something to the effect, more or less, that if we're going to let a program do something that's critical, and once we start that program, we're not going to be able to stop it. Well, we better be sure that what the program is trying to do is what we want it to do, right? And so that's so important. And so I have two reactions to that. The first one is, well, just don't let programs take care of everything without having some supervision over them, right? So certainly things like auditing and so forth, those are extremely important. But as long as there's supervision in the process, I think we're going to be much safer. And the second thing is that in terms of being sure that the programs are doing what we want them to do, we have to remember when we're talking about some of these health data sets that often the gold standard that's there, for example, in terms of diagnosis or recommendations, those are put there by people, right, by human experts. And so sometimes when we talk about predictive performance of the machine learning model, when we say it's doing very well, what that means is not necessarily that it's getting the diagnosis right. What it means is that it's getting the sorts of prediction that it's supposed to do close to what the experts said, right? So a better performing model isn't necessarily a better model, it's just one that kind of parrots the sorts of things that people put into it more faithfully. So that's an important thing to keep in mind. And thinking about these other dangers also, that we can kind of turn it around, hopefully, right? It could be that in certain cases, if we use sufficiently powerful machine learning models with sufficiently good data, they'll eventually catch on to patterns in data and be able to make predictions that are sometimes, as we're saying, better than people. And so isn't it there the possibility, and perhaps we should work on this more, of in some cases, using those kinds of things to detect bias and labeling. Right? In other words, we look at these data sets and see what doctors recommended, it could be the sufficiently good models can help us to figure out that there are certain biases against certain groups in particular, or certain individuals, just based on the fact that these machine learning models kind of together agree on a certain different diagnosis than what the original experts said. So I think there's hope there. And kind of as an overall trend, because you focused on pointing out these pitfalls and everything, I want to reemphasize something you said at the beginning, which is that machine learning is a force for good. It can be a force for good in healthcare, right? It's doing great things for people, getting these great diagnostic recommendations in particular, right? So we shouldn't be fearful of the machines. It's just that we have to be kind of a little bit aware of some of the risks that their use entails. Another thing is that there's several sources of bias, as again you pointed out, right? So there's bias in terms of the representation of people within, or groups within the data itself. There's also bias that comes up in the way that some of the algorithms sometimes intervene and so forth, right? There's bias from all these different places, but I think it's extremely important that we focus, people who do research in this area, on pinpointing what those mechanisms are in a particular case, right? Some methods might be better than others. For example, you look at, I forget what example this was exactly, but you compared several different predictive techniques, and it was clear that the variability of those techniques in terms of their immunity to the amount of noise that was present, right? That this varied quite a bit. So we need to be able to see what things are going wrong, in what cases, right, under what conditions, pinpoint them a little bit more. So that'll allow us to get better machine learning models, better disease models, right? Better processing and better policies, right? Because this is really very much an interdisciplinary problem. It's not just about the models and the design and the engineering that goes into them. It's not just about the doctors. It's also about the procedures that are in place from a societal perspective, right? Is it possible the data quality simply is really uneven across populations, right? This kind of thing. And so certainly policy is an important thing to do here. One of the examples you gave also just reminded us the African Americans and whether in the context of mental health, right? There's evidence that African Americans are diagnosed at over twice the rate of schizophrenia than other groups in this country, right? And so it could be, certainly, there's a possibility that that's an objectively correct thing, but more likely than not, it's probably also biased in the way these things are addressed. So some sensitivity to some kind of social and social determinants of health, I would say. More attention is needed for that. In terms of machine learning related mechanisms, if there are any people who are more specifically in that audience here, in that group here, there are a couple of things that I think machine learning designers can do. I think that just by pursuing better performance, we can actually, well, we'd be making a mistake, and just focus on that. But on the other hand, there is evidence that, at least indirectly, pursuing better performance could indirectly help to reduce bias. And that's simply because a very biased system will be very poor at generalizing, especially in the case of distributional shift, this kind of thing. That's not enough, of course. We need to do directly auditing and other techniques that help us kind of catch the bias more directly. Another thing I want to point out that's very important is transparency of these methods, right? So the AMA in particular, which has released in the last few years some guidelines and recommendations for the use of AI, and by AI, they define it not as artificial intelligence, but augmented intelligence, right? Some of the recommendations include not only the control for bias, but also transparency of the models. And so this is a real challenge that we have right now, especially because these deep learning models, the BERT models, and other kinds of things, they're extremely good as predictive models, but they're very opaque. If you try to open up the box and try to get a paper trail, so to speak, for how the model arrived at its predictions, you can't do it. It's very difficult. There certainly are techniques that try to go in that direction. You mentioned the feature occlusions, for example, and maximizing activations based on what inputs are most associated with maximal activation within those networks. But it's very hard to get a consistent, coherent description of how the models arrive at those predictions. I think that more work, both in terms of understanding the currently best performing models, as well as additional work in different architectures and approaches that would be more understandable to people. I think that's also a very important thing. And finally, I would say, because I know there are computer science students in this audience, I think we as computer scientists need to do a better job of incorporating ethical reasoning into what we do, right? In computer science, for example, we have a course on the social and ethical implications of technology that some students take and some students don't, right? We have to integrate that into the fabric of the thinking that goes into everything we design, right? Because it is our responsibility, right? The buck stops here. Nobody else is going to take care of making sure that the things that we design, the project programs we design, are fair and unbiased. So just something to think about. And I guess it's really a multidisciplinary conversation that we all need to have.
Yeah, thank you, Sergio. Other fantastic comments here. I mean, I'm so proud to be sitting up in this in front with folks like yourself here who are so knowledgeable and so thoughtful about these very important problems. I think what I'd like to do is ask for questions from the audience. Oh boy, here we go. There's a student in the back. Here.
Yes, so in a world where it's so difficult to eliminate bias between the models.
You know what? We're going to give you a microphone.
Oh. So without access to good data, diverse data, it's very hard to eliminate bias. So my question is it more important for researchers today to focus on improving the models themselves or to do research on the deployment of the models so that people don't just, clinicians don't blindly go with the model's recommendation and they understand the predictiveness for a given patient?
I think that both are important. I think that the thing that I worry about is that there are quite a few people that think about the first problem. So if I think about any of the universities here in Boston, I can think about a person who is working on making models better in sort of these health contexts. There are not many people who think about the second thing. It's a much harder problem. And it's also something that as a mind space has not been well tackled. Like NASA did all of the fantastic research on how you present very intense information to highly trained people that they sometimes need to ignore during space flight and sometimes really need to focus on. And so there's a bunch of human-computer interaction research that was done by them a long time ago, like 60s, 70s, a little bit in the 80s. This has also been done in like the sort of aviation industry. Like what information do you give to pilots who are experts, who are making decisions with assistants, but sometimes need to ignore maybe the devices and do something else. We haven't done that in medicine. Nobody did those studies. Same situation. Here are experts. They're making decisions. Sometimes they should ignore maybe some of the things the devices are telling them. And we have no established depth in how to present information. We have very annoying systems. I don't know if you've ever, been in an ICU. Everybody hates those machines. Like the nurses are like, oh, it's terrible. It is terrible. Like everything beeps at the wrong time. Nothing is set up to be easily accessed. Like all the alarms, they interfere with one another. There's a great study that a PhD student did when I was graduating, Matthew Gombolay, who I think is at Emory now. And it's a great study where he worked in an obstetrics ward in the Boston area, and he had a model that was an optimal flow model. And so all it did, babies are going to be delivered, right? And there's a staff to deliver them. And all it said is Dr. A, go to room 2. Dr. B, go to room 7, right? Just a timing and expertise kind of match thing, right? And he had a bunch of interesting algorithm stuff in it, and I didn't care about any of that. What I cared about is the last paragraph of his paper. He said, we tried to deploy the model in 2 ways. First, we tried to give it to them as like an alert in the EHR. And they ignored it. They're like, don't tell me what to do in the machine. Like, I go to the room, that makes sense. And then they got a cute little anthropomorphic robot that said, Dr. A, go to room 2. And they were like, okay. That's ridiculous. Like, so, yes, you can put all this effort into making that really optimal model. But if the cute robot doesn't tell you to do it, like maybe you won't listen. So both are important, but nobody's looking over here.
So I want to add, if I may, that I think it's important to try to build more interdisciplinary groups, right? Because I think that if the medical personnel, and this sounds odd because I don't think it's done that much now, if they were involved somehow in the design stage, then I think that the processes that result from the deployment of some of these machine learning systems, I think that would be more effective. And in fact, I remember from the American Medical Association's recommendations, they actually said that. They said that medical personnel should be involved in design. So I think that we have to somehow figure out some sort of protocol where this is going to be facilitated.
Yes, Sasha.
So a little bit to that point, I sometimes feel like we are training the algorithms are training us. So when I go to doctor, I feel like I'm filling out the data form that I know is going somewhere. I actually had a guy that completely misdiagnosed talking about the probability.
Yeah.
We had a great conversation. I'm an economist, but I actually had a serious illness that he didn't catch. So, and to your point about the prescriptive versus descriptive outcome from the model, and to Sergio's point about interdisciplinarity, it's a fundamentally different decision. If you're asking me to interpret the transcript with the flag and the transcript with the prescriptive,
Exactly.
because with the prescriptive, I actually have to overcome something that can later come back and bite me. It's like Bill de Blasio, closing down New York for 3 inches of snow, because had it been 6 inches like the model predicted, and he hadn't closed the city, the consequences are much bigger, right? But I have actually a more technical question. So you put an example of the model that was trained on biased data. Then you feed, not on biased data, but lacking data, right, with very little representation. And then you feed it a much more representative sample and you get biased results. At what point do you retrain the model? Because, or did you retrain the model when you were missing?
So that specific model is a deep metric learning representation. And so deep metric models or deep metric learning in general is a generalization of contrastive learning, where you're not trying to train a model to predict something. You're trying to train it to represent something well, and then you can release that representation. So in the face example, if we're taking faces, what I would do is I would take 20 different photos of my face, different angles, doing different things, and say, but these are all Marzyeh's face, and then 20 for Sergio, 20 for Summer, and then the representation, the actual topology of the representation, in theory, is going to learn how to identify noses well. I never trained it to predict noses, but now this representation itself knows how to, that this face is the same, is the same, is the same, and so internally there is some representation for noses, and so then what you do is you put a downstream classifier with balanced data, and then you project it onto this representation, and then you train for the thing you want to predict. So when you take Celeb A or any of these face data sets, right, that are publicly available that people use in image recognition, they have very few Black faces, right? And so if what you do is say, learn some representation that just recognizes people's faces well, and then you try to predict smiles from the faces. It's bias in predicting smiles that we're seeing, a downstream label. So let's say I start with 80 white faces and 20 Black faces, and then the label that I'm giving the model is this the same person's face? And, for consistency reasons, the same person, the white people will be white from any angle, Black people will be Black from any angle, okay? And so now I've trained a model and I've given it, this loss function that penalizes not knowing the same person, right? The representation is trained, it's fixed, right? I have some fixed like representation. So now I come with a new data set that is half Black and half white, and I want to predict smiles and whether a person is smiling. I will predict significantly worse on all the Black faces, whether they are smiling or not. So but my new data set is balanced, right? So I'm training a new model, but when I project it into the embedding space doesn't have good alignment for features on darker faces.
My question is, why not start from scratch?
I see. The reason that we're not, if you restart from scratch, it fixes it, right? Like if we have all the data and everything's fixed, it fixes it. We don't have all the data. So, the problem is all of the data sets that I have access to in a health setting, there's like 10 people in this bucket, right? Like there really are. And so often just for like technical validity, I exclude them. I exclude Native American women. I don't look at them as a category because it's not technically valid to do the analysis on a subgroup that's this small. And so if we had it all, yes, it would fix this problem. Just redo it from scratch and it's fine. But a thing I get told a lot from people is just train it now. And when the data gets better later, we'll use the models and it'll be fine. And it's like, no. This is going to be a propagation of bias, right? And so That's the point of the paper. Yes, trivially fixed by having good data from the start, which, yeah, I wish we had.
Other questions?
Thank you so much for a wonderful session. I'm Corinne Durgans from the School of Nursing, and I think this whole talk was designed for me. I'm a critical care nurse, and I've got two groups of students that are working in bias, one to remove race-based medicine from a huge clinical practice, and the other to look
I feel like you're
at
speaking my language.
another that's looking at enrollment in clinical trials in the Mass General system that represents the community. And they are specifically looking at Alzheimer's, which of course we know has a high percentage of African Americans, but guess how many people of African American descent are in their clinical trials?
Yeah.
This much. So all of our results are being biased. So my question is really about being a boots on the ground clinical researcher and the problems with enrollment, because enrolling people in studies is challenging to begin with, and there's a large distrust in some of our marginalized populations. So right away, we're biased. So that's one point. And the other is in the electronic health record, when we went electronic, it's like checklist charting.
Yeah.
So that's also a problem.
Yep.
And then the third point is about the insured. If you're on Medicaid, I live on Cape Cod, you have to go across the bridge to get care. So there's where you get care and access to care is very problematic. So
Yeah.
I know this is a societal policy problem, so maybe interdisciplinary wise we can approach it, but I think it's so long-standing, we've got a lot of work to do.
Thank you.
Thank you for the wonderful session, and I truly learned a lot. I came from the Lynch School, and several takeaway messages I got. I do statistics that when you talk about all of this, the replication of the data, and when we draw conclusion from the machine learning method and models, and what kind of feel that, oh, this is very powerful and powerful methods, powerful data, and we draw some conclusion, but how replicable of the study is. That's one thing that we always, as a methodologist, as a statistician or machine learning scientist, we have to pay attention to. And the second thing is, in terms of the data quality, we have a lot of things to consider. And also, when we look at the huge number of data, machine learning methods are very powerful. And we also look at a lot of specialized cases and groups with a small number of data. And we also need to incorporate case studies in small focus group combined with machine learning to study whatever the real interest and the research questions we cannot get rid of it. And it's very important to have that mindset to incorporate what we have studied for many years in the past 100 years, the established methods that work for small groups and marginalized groups, and combined with the machine methods. And third point I want to mention is the reliability and validity issue. We talk a lot about this. Are these methods reliable? Are the results consistently, across different studies, across different groups, across different samples of population? For big tech companies, we do have very powerful machine and models to work on. And for lots of application area in social science, social work, and in health field, in education field, we do not have that much amount of resources and money. And how do we incorporate that mindset in decision-making process and even curriculum component training to incorporate what we already observed? Like what you mentioned in that example, one question, that questionnaire, if you issue that questionnaire to 10,000 people, that's 10,000 impacts to individualize people's life experience. But if somebody take a step to re-evaluate this process and change that question, how you ask that question, then that experience is different. That feeling of bias or that feeling of compounded, being treated differently, that feeling will be changed. So I think the evaluation process is very, very important in the whole process and decision-making process. People who have more weight and power, how they treat this, how they look at our results from machine learning or statistical methods is also an important part. We need to remind the powerful people to put it in the system as actionable behavior. And it's also measurable behaviors. I think that's how we can start. Thank you very much.
I really I like what you said, and I want to emphasize, somebody told me at the end of a talk I gave once, so we should not do machine learning, right? And I'm like, no, that's not what I just said. But, you know, what Sergio had said, I want to emphasize, like, the machine learning model is not evil. It doesn't want Black people to die. It's learning from data that it's showing that in general, certain kinds of care don't go to certain kinds of people. That's a human process problem. And one of the things I like about the work I do is there are decades of research in social epidemiology and policy that are saying, like, maybe there's worse care for some people, right? But suddenly when you say, are you comfortable with me having an AI do what you're already doing? People say, no, I am not comfortable with that. So maybe we should change the process so that doesn't happen in the first place. I'm also a very big fan of regulation. I think that audits should happen more often. Why aren't doctors audited? Surgeons have that 30-day post-surgery mortality score, like how many people that I operated on did they die within 30 days? I would like to know if my doctor killed every single Iranian woman he saw. It would be convenient for me to make decisions about my own healthcare, right? There's no way for me to audit easily within a system whether, for example, there are significantly worse health outcomes for African-American women for a specific doctor for maternal care. And that is something that we should know. That's something that relates to, not just the models that I'm learning and so potentially health that could be, healthcare that could be propagated, but also just as a system, right? Like we as consumers have very little information about how these experts that we are putting our trust in, that are a self-policing body. There's no federal agency that comes in and checks that like you are, doing whatever, like doctors police themselves, right? Like they check to see whether they're performing well. And so I really think that there should be more regulation of this space, if for nothing else, so that when we're learning on data, I can flag in a EHR record that maybe we don't want to include this doctor's performance in the model. Maybe we could like skip that one, right? There's no way for me to do that right now. I have no way of identifying that maybe this is not a person I want to learn from.
I have actually maybe a little bit of technical question, but it also relates to what Summer said, Marzyeh said, Sergio, and thinking back to Ruha Benjamin's talk yesterday, also the concept of intersectionality and statistical models or machine learning models. And I'm thinking about it from my statistical perspective. We always talked about interaction terms, and Summer, you mentioned interaction terms. And what I'm hearing a little bit of is, I can't quite tell if you're saying that interaction terms aren't a good way to capture intersectionality, or that they are, but we'll have to be very careful about that, or that they're not powerful enough to do that. So I wonder if you could talk in the terms of, these more traditional statistical models, where intersectionality can needs to be inside of these sorts of models.
I'll start then. Yeah, I think it's just that we traditionally have always been taught in statistics in every field, like you put in an indicator for age, right? You put in one for sex and one in for race, ethnicity, and education. And we forget that people aren't in just those individual buckets, right? We know that certain of those intersections may be at higher or lower risk for an outcome. And so I think it's really trying to create our variables, whether it's from an interaction or whether you create a combined variable, but really identifying the fact that if you don't look at some of these intersections, you're missing the boat, right? You're missing the fact that Black women are going to be underdiagnosed, for example, in that lung screening case than white females, right? And we wouldn't know that if you were just looking at race separately and females separately. So I don't think it's that it's anything revolutionary and that we can create different variables, we can create an interaction. But if we don't think and recognize that people are not in those buckets, like, right, we know that people straddle many different ones. And that brings up the point about small cell sizes, right? That's the challenge, is that if there's too many, clearly we'll have two people in every bucket and we can't actually generalize our results to anybody. So there is a fine line and I don't have a perfect solution. But one thing I wanted to ask about when you said about there's not enough Native American women in, I don't remember which data set it was, is it that there's not enough data available, like they just don't exist, or is it so hard for us to get them? And I think that's the other issue, is making it easier to get accessibility to some of these data sets that would then give you more representation. So for all the data, you know, all the papers that are like, oh, can you post your data online? No, actually I can't, because the CDC says that I can't, you know, I have to go through vital statistics, or I have to go through every single state's health insurance claims data because I can't post it, right? These are private. So I can't ever, like, transparency and reproducibility is really important to me. But how do we then break down those barriers to get accessibility to data, particularly that we know it's there and we want you, for example, to be able to use all that data available?
I think that data should be available. I don't think it should be
Is
private.
it there? That was like the
In national representative data sets, the data is there, right? Like it exists in private data. And the thing about private data is it's sold, right? And that is a very difficult, unless it's a nominal, like everybody pays, you know, $100 for forever access, like the UK biobanks, right? Like there are some data sets that have a nominal like admin fee just to set up your crew. That is not what insurance data is like. And I am a big advocate of actually trying to regulate that industry, because I believe that data should be public. And I believe that federal agencies should actually step in and require them to allow releases. And we have HIPAA. We know how to compliantly release data, right? Like there are ways to do this. This is not a technical problem. It's not a legal problem, because HIPAA exists. It's a financial thing. And so in the data sets that we have access to, right? So like local hospital data sets that are willing to share, the data's not there. It's just actually that there are like 2 Native American women, which is horrifying, right? Like that's just what we have, right? But I know the data exists in these larger like entities. I also know that they happily sell it, you know, to many people, you know, for whatever cost, for whatever term. That's not a good solution, right? And you know, many hospitals are the same way, right? Many local Boston area hospitals will happily sell you their data or sell big tech companies their data, but they won't give that data to researchers, even though it's legally fine, right? They're selling it anyway. It's de-identified, and there are ways of protecting it with legal teeth. And so I think that there should be a much stronger incentive. And so I think the NIH should say, as they have recently, that if you touch NIH money, the data has to be publicly available, maybe behind a verification wall, which is true for some of their studies, right? I have to verify my identity, prove that I have training, but I can access it, right? Or maybe in a redacted way. So, you know, oh, we have a small cell problem here, and so really we can't release any of this. But in general, this is not a problem that is technical or legal. It's a social problem. It's a capitalism problem. It's so annoying that this is like, people always tell me like, oh, you don't care about privacy. I love privacy. This is not about privacy. This is about money. And it's annoying when people like, I get very annoyed when insurance companies or hospitals imply that I'm a crazy machine learning data person. No, this is a solved problem. We know how to fix it. You just care about the finances here. Yeah. Really shocking. People are like, this is about privacy. It's like, I am not stupid. Do not try that. Like, no.
I can say, yes, data availability and data sharing was just absolutely crucial piece of the puzzle. And so I think what you said, coming back to your point, Laura, or you
Yeah.
were asking about the multiple variables and such. So
Yeah.
one of the advantages, I guess, in principle of machine learning is that they're capable of extracting these multivariable kinds of associations in a way that's very effective, right, in principle. So these representations that Marzyeh is talking about, these are basically, they're reflections of entanglements among, in principle, all of the variables. The good thing is, yes, it works quite well. And the bad thing is the models are not explicit. So you can't tell very well exactly what the interaction terms are unless you kind of go in and kind of take things apart on one hand. And still, the problem remains sample size also,
Yeah.
right? You need enough data, issue sample complexity, you need enough data to be able to infer the right kinds of patterns, especially when it comes to these kinds of intersection terms and so forth. And sometimes it just isn't enough. So getting back to the original problem and importance of focusing on sharing data more widely available.
We have time for one more question. If there's another question out there in the audience. Anybody? We'll give a few seconds. Someone who had a thought, wasn't quite sure they wanted to share it, but now is the time. Yes.
Hi, this is Mo from Communication Department. I'm studying users' perception of AI, so it resonates with what Laura said before. We call it machine heuristics. So people do not have ability and motivation to understand very opaque computational behind the interface design. So we just use the cues or heuristics. Oh, that was coming from AI or machine. But we easily think that they evaluate the interaction as objective or neutral or non-biased or consistent, so that I have my own experimental evidence that people do not, also studying fake news, so that we have hard time making the fact checker as a neutral referee because partisans see the fake news and the fact checking messages in their own advantages, like whatever information that is hurting them, they don't want to accept it. So they do not trust fact checking messages based on their partisan
Partisan
motivation.
identity.
Yeah. So that partisan bias, reducing the bias is very important. So that when we label the fact checker as an AI, people tend to reducing partisan biases compared to the fact checking source that is labeled as a human experts or groups. So my question is, like your work is that you first ask us, would you use the AI doctor or the machine learning doctor?
Yeah.
And a lot of people say no. And actually in my class, I ask students who didn't want to get advice from the previous IBM Watson doctor. But at the same time, one of your finding is people take that advice as they are.
Yeah.
So it's kind of conflicting part. So
Yeah.
how would you do you have any idea about people's perception about that?
So there's been some very good research on this in the robotics community, specifically in the rescue robot community, right? Because we often in the nuclear reactor meltdown, right? They didn't want to send more humans in to get exposed. They wanted to send in a robot, right, to help people get out. So there's a really robust research community at Georgia Tech. I think Ayanna Howard, who does some of this. It's very good research. She has some really fascinating results on, there's two things. It's called algorithmic aversion. So people have there's not a good word in English for this. You know that reaction when something's a little bit icky and you go, ooh, there's a word for that in Farsi, it's tarjuf. People tarjuf when they think about, oh, an AI is going to do that? Ooh, I don't like that, right? People have that. But then when the robot is actually giving them advice, they follow it, they anchor to it. And it's for two reasons in the robotics community, they've established this. They assume that the robot has access to information they don't, right? You're leading me this way, you must know something I don't, right? I believe that because it takes a lot of intelligence to build something like this, like you must know the exit path, right? And you also believe that the robot maybe has agency in some way that maybe you do not. So you believe it has expertise that you do not, and you believe that maybe its directives come from some source with some agency, right? It was deployed by the rescue team or the fire station or whatever. And people in her experiments followed the rescue robot towards the source of fire. right? So what they did is they had a room like this, and I don't know how they got this past IRB, but they like made a pretend fire happen. So they piped smoke under the door, and then they like made it hot in like a supply closet, and then they had like smoke pouring out from under this door, and there's like stairs that will lead them to safety. Clearly on this video, you can see the video, it's disturbing. And they're following the robot that says, I will lead you to safety towards the door that the smoke is billowing out, like they're following, like, oh, it's leading us to safety. So, you know, yes, I think in our minds, we hope that we, or if you ask us when we're not presented with a situation, we don't like the idea of being influenced by other people. You know, an algorithm is maybe worse. Like we have all of these ideas about who we are and how we make decisions. But what we say we are and we want and we will do is not what in practice we actually do. We've also compared what happens when you give expert and non-expert doctors advice and you say it's from an AI or you say it's from another radiologist. You're evaluating a chest x-ray, we give you the wrong advice, right? We say it's pneumonia, it's actually a pneumothorax, right? And we say an AI model said this, or we say that a doctor did it. We did it. It's all us on the back end, right? We're just telling them this. They claim that the advice from the AI, even though it's the same advice, is lower quality than the human advice when they rank it afterwards. But they follow it just as often. When it's wrong, they follow it just as often. They listen to the wrong model just as often. And so I think there's this clear dissonance, even in experts, radiologists, they do this all the time. It's what they do. In what we think we're going to do and what we actually do. And so I think that's why it's really careful to think very, very stringently about when we're giving model advice, people are probably going to listen to it, even if they are very good at what they do. And so we want to be very careful about when it's wrong and who it's wrong on.
All right, well, this has just been a spectacular panel. I am so grateful to you. The Schiller Institute is grateful to you. The Data Science Institute is grateful to you. Thank you for your talk. Thank you for your insights. Thank you for responding to our questions. It's about hand applause for our panel.